Hello everyone, welcome back to this channel. So today we are going to study about the cardiomyopathies. So how do we define cardiomyopathy? Cardiomyopathy are structurally and functionally abnormal heart. What type of structural abnormalities we can get? We can get hypertrophy, we can get dilatation, right? And what about the functional abnormalities? There could be systolic or diastolic function, right? So cardiomyopathy is a structurally and functionally abnormal heart, right? Coming to the types, the cardiomyopathy is divided into the three parts. The first one is dilated, hypertrophic, and the last one is a restrictive one. With dilated cardiomyopathy, we have an enlarged chamber with the weakness, right? About the hypertrophic cardiomyopathy, we have an abnormal thickening of heart muscles, and the restrictive one is having with the stiff wall, so that there is a very less pumping action which results into decreased cardiac output, right? So this is the usual classification of cardiomyopathy, but there are a few other cardiomyopathy that exist and we must know them as well. So those are arrhythmogenic right ventricular cardiomyopathy. In this, there is a right ventricular which gets replaced with the fibrofatty tissues. This replacement results into decreased cardiac output, and that's why we get systolic and diastolic symptoms. The second one is Takotsubo cardiomyopathy, and it is associated with the trigger, which is mostly the emotional or very stressful condition. This emotional stress result into left ventricular apical ballooning, right? And so that we get the systolic and diastolic dysfunction, right? Then there is a left ventricular non-compaction syndrome. It is associated with abnormal embryonic development. In this case, we get ventricular myocardium as a spongy. So there is an ineffective contraction and there is a decreased cardiac output and ejection fraction. So the symptoms of cardiomyopathy we can get. The next but not the least is a tachycardia induced. So due to constant tachycardia, there is a dilatation of heart which results into cardiomyopathy, right? So these are the other cardiomyopathy that we can encounter in our practice. There is another classification of cardiomyopathy that exists which is based on the etiologies. So let's focus on those etiology based cardiomyopathies. So we have a peripartum cardiomyopathy, we have drug induced cardiomyopathy, we also have this cardiac induced cardiomyopathy, we have just myocarditis which results into cardiomyopathy. So one by one, let's study about those cardiomyopathies. The first one is a peripartum cardiomyopathy. So the meaning lies in the name itself, and it is a postpartum, that is after delivery or within the third trimester. So it occurs at postpartum or third trimester. It is usually associated with the age more than 30, right? And most of the time it has also association with the hypertension. Now there is a routine question, or we can say that it is a high yield point about SFLT1. So SFLT1 is an anti-angiogenic factor, and it is associated with peripartum CMP, right? What clinical features we can appreciate in this peripartum cardiomyopathy? There is a left ventricle systolic failure features. We will discuss this systolic failure features just within a minute. But the key point to be remembered in this peripartum cardiomyopathy is that there is a symptoms at exertion or a breastfeeding, right? And which is associated with the diaphoresis. So this is about the peripartum cardiomyopathy. So the next thing about the cardiomyopathy is a drug-induced cardiomyopathy. Anthracyclines like doxorubicin, daunorubicin are important causes for cardiomyopathy. Then there is another drug called as trastuzumab that we used in breast cancer, is also responsible for cardiomyopathy. In addition to this, cyclophosphamide, anabolic steroids are important causes for drug-induced cardiomyopathy as well. Heavy metals like lead, mercury and hydrocarbons with the toxic dose leads to cardiomyopathy. About the cocaine, there was a question in NEET PG and the total history about the cocaine consumption was there with few cardiac symptoms, and it was asked about which type of cardiomyopathy that we get in cocaine. So dilated cardiomyopathy was a right answer for this question. Moving forward to alcohol induced cardiomyopathy, what happens in this alcohol induced cardiomyopathy is there is a constant increase in aldehyde, right? And this aldehyde is responsible for the cardiomyopathy. Okay. Now there are few myocarditis that are also associated with the cardiomyopathies, and those are inflammatory dilated cardiomyopathy, which usually associated with the viral infections like HHV and the Chagas disease. Chagas disease caused by Trypanosoma cruzi. Right? Now inflammatory dilated cardiomyopathy can be associated with focal involvement or the diffuse involvement as well, right? So what are the clinical features of this myocarditis? The clinical features are very subclinical. Those are very subtle clinical changes that we should observe in ICU. I'm just giving an example. Whenever there is a patient with this myocarditis, like inflammatory dilated cardiomyopathies, we have a patient with the Chagas disease, and usually those patients are with the ICU supports, and we are treating that Chagas disease. But out of nowhere, there is somewhat unexplained tachycardia and hypotension. Then we suspect this patient to be having cardiomyopathy. So there are very subtle clinical features or subtle changes that we get into the patient. So these are very subclinicals. Also note that there are chances of increasing tropi in those conditions as well. Right? Most important high yield topic about this histopathology is the Dallas criteria. So remember, Dallas criteria is for myocarditis induced cardiac myopathy. So it uses histopathological studies to help the diagnosis of cardiomyopathies in myocarditis, right? For the investigation per se, we usually go for MRI, in which we can get peripheral enhancement, right? So this was other classification of cardiomyopathy depending upon the etiologies, right? Now there are few high yield points or one liners we should understand. The peripartum cardiomyopathy has the best prognosis among the dilated cardiomyopathies, right? Because what? Because it is due to pregnancy and it is very transient, right? Then peripartum cardiomyopathy has a high recurrence risk. That's why we advise those patients not to get pregnant frequently, or we ask patients to delay their pregnancy or to increase the interval between two pregnancies as well, right? Alcoholic cardiomyopathy improves after alcohol cessation. Perfectly acceptable. Then anthracycline are important cause of drug-induced cardiomyopathies. HHV6 is a common viral cause of myocarditis which results into cardiomyopathy, right? Myocarditis may present as an unexplained tachycardia and hypotension. I want you to note this sentence about unexplained tachycardia with hypotension in myocarditis patient. What will you suspect? And the answer would be cardiomyopathy, right? Also, there might be the troponin elevation, and the MRI findings support the diagnosis of myocarditis, right? So this was all about the basic thing about cardiomyopathies. Now let's discuss about the hypertrophic obstructive cardiomyopathies. The name itself tells that there is a hypertrophy of heart muscle that result in the systolic and diastolic dysfunctions, right? So HOCM is usually autosomal dominant inheritance. There is a most important point in this HOCM is that there is a positive family history of sudden cardiac death in young athletes. The one thing that we usually ask those patients is whether there is any family history, whether there is a history of sudden cardiac death in your siblings, and if there is history, and if there is the presence of any history, then HOCM can be suspected, right? So positive family history is one of the key points that could be asked in your questions, right? Then what is the genetic deformity that we have in this hypertrophic obstructive cardiomyopathy? And it is a sarcomeric protein defect, and it is associated with beta myosin heavy chain, that is MYH7, right? Also it is associated with myosin binding proteins. So these are the various proteins that are defective in myocardium. So there is a hypertrophy of heart muscles, right? one thing I want you to note that the hypertrophy is usually a symmetrical hypertrophy. As you can appreciate, there is a hypertrophy which is usually more at the interventricular septum as compared to left ventricular wall, right? So asymmetrical hypertrophy in interventricular septums more is a characteristic feature of HOCM. Now let's understand what is the LVOT. LVOT. So it is a left ventricular outflow tract. Now understand, this ventricle is connected to aorta. Suppose this is your aorta, this is your left ventricle. The tract through which blood flows from left ventricle to the aorta is this gap. It is known as left ventricular outflow tract. Now please appreciate that there is a hypertrophy of this interventricular septums, due to which there is obstruction or there is a obliteration of this LVOT, right? Here you can appreciate the LVOT has no obstruction due to normal septum, but in this case, due to this hypertrophy, the LVOT has been decreased, right? Now understand with this simple diagram. Suppose this is your LVOT. Here is a left ventricle and here is a aorta, and this is your normal tract. But due to the hypertrophy of these muscles, right? So these are the hypertrophy of muscle. There is a obliteration or there is a narrowing of this LVOT. So this is called as a LVOT obstruction, right? One more thing I want you to understand about the SAM, that is a systolic anterior motion. Now understand, what do you mean by this systolic anterior motion of mitral valve? Understand, this is your mitral valve and this is your hypertrophied septum. Now the distance between this in HOCM and the normal intraventricular septum, what do you think? Which distance is more? Of course, when there is no hypertrophy, the distance between this mitral valve and the interventricular septum is more as compared to HOCM. So the distance between this interventricular septum and the mitral valve is decreased, right? So this anterior leaflet of mitral valve comes close to this interventricular septum. Due to this, there is a dynamic LVOT obstruction, right? So the anterior movement of mitral valve results into dynamic LVOT obstruction. Again, the distance between interventricular septum and the anterior leaflet of mitral valve decreases in HOCM. That's why there is an anterior movement of mitral valve leaflet which results into dynamic LVOT obstruction. So these are few terms that we must understand about this HOCM. We have covered LVOT outflow tract, then we have covered systolic anterior motion of mitral valve. Now let's start with the pathophysiology. So the pathophysiology is very important in terms of HOCM, because as soon as you understand the pathophysiology, it is better to study overall disease, right? So the pathology starts with the asymmetric septal hypertrophy, right? So interventricular septum having a more hypertrophy than left ventricle, right? This hypertrophy results into the small stiff LV cavity. What happened after this small stiff LV cavity is there is a decreased compliance. What do you mean by there is a decreased compliance? There is a decrease in change in volume with respect to change in pressure, right? Due to this, there is a diastolic dysfunction. The left ventricle is not able to dilate as normally as it should be, right? So there will be increased LV filling pressure, the LV filling pressure like left ventricular end diastolic pressure. So this pressure will goes up, right? This will result into the pulmonary congestion and we will get dyspnea and heart failure, right? So this is our diastolic dysfunction. Now what about the systolic dysfunction? This one is our systolic dysfunction, right? Here what happens, there is a narrowed LV outflow tract. As we discussed earlier, there is a LVOT obstruction, as you can see here, right, due to interventricular septal hypertrophy. What results into this is, this results into rapid systolic blood flow from this closed space. Now understand, if the blood is flowing through this unchanged diameter, there is no turbulence, right? But whenever there is a constriction or obstruction from walls, then there is a turbulence of blood, or there is a turbulence of fluid. So the same thing we get here in HOCM as well. So there is a systolic anterior motion of mitral valve. This results into the dynamic LVOT obstruction. The word dynamic is also important because the examiners are very clever. They will put dynamic, static and few other words, and they will ask about whether it is dynamic or static. So it is a dynamic LVOT obstruction. This results into a decrease in cardiac output, which results in syncope, exertion and symptoms. So the other symptoms related to decreased cardiac output, we can appreciate and we can think about all those symptoms as well. Now this results into the improper mitral valve closure, and there is a mitral regurgitation as well. And due to this mitral regurgitation, we get left atrial enlargement and atrial fibrillation as well. So the clinical features with this is a palpitation. We have covered the dyspnea, orthopnea, PND, right? The decreased cardiac output is associated with the symptoms like decreased cerebral perfusion, and we can enumerate those symptoms as well, like there is a syncope or there is a altered sensorium and so on. Also we can get the decreased perfusion towards the kidney, which results into the RAS activation, right? And this will also create the fluid overload and sodium retention as well, right? So the cycle goes on with all those heart effects, right? Then after this, there is a massive left ventricular hypertrophy, which requires increased oxygen demand, and due to this hypertrophy, there is a decreased coronary perfusion as well. This causes myocardial ischemia, and the chest pain and the fibrosis are there in almost all HOCM, right? This all cascade results into myocyte disarray, fibrosis and ischemia, and this is very bad for the heart muscles, which is prone for electrical instability, and there is a huge chance for VT and VF and sudden cardiac death, right? So this is a full pathophysiology of hypertrophic obstructive cardiomyopathy. Now let's study about the signs of this HOCM. About the abnormal signs, we get jerky pulse and spike and dome pulse. We called it as a bisference pulse. Now understand, this is what we get in HOCM. Now the first spike is due to LV contraction, and the second spike is due to dynamic LVOT obstruction, causes rapid early ejection followed by mid systolic obstruction. So the mid systolic obstruction results into the second spike, right? So for the pulse, there is a jerky pulse and the spike and dome pulse, which is a bisference pulse. So this is a characteristic feature of HOCM. Then we get the forceful double apical pulse. It is due to two things: due to vigorous LV contraction and atrial kick into stiff left ventricle. Also there is S4 heart sound. I hope you remember those cheat codes, and we have discussed about S4, and it is due to atrial contraction against that stiff non-compliant LV. So left ventricle is very stubborn and it is stiff, and to push blood towards the left ventricle, atria has to contract, right? So that atrial contraction results into S4. Then there is a harsh ejection systolic murmur. Why? Because there is a narrowing of LVOT, what we discussed. So it is like this: outflow has been decreased. So whenever LV contracts, it pushes blood from this obstruction, and this gushing of blood results into ejection systolic murmur, right? Murmur best heard at the left sterner border apex. It is a site of LVOT obstruction. Now the most important thing about the murmur is Valsalva and squatting. Let's understand with this diagram. Now suppose there is a decreased preload, right? What will happen if there is a decreased preload? There is less amount of blood in left ventricular, right? Since there is a less amount of blood present in left ventricular, there is a decreased distance between this intraventricular septums and left ventricular wall, right? So more the wall are near, the more LVOT obstruction is there, right? So whenever there is a decreased preload, there is a smaller LV cavity which causes more LVOT obstruction, right? So distance between this is decreased, and so that there is a LVOT obstruction in greater extent, right? Suppose there is increased preload, then the amount of blood that is present in the left ventricle is increased, right? So the distance between this two interventricular septum and left ventricle wall is increased, right? So the more blood can be occupied into the left ventricle, right? So there is a decreased LVOT obstruction. So what do we get in Valsalva or standing? In Valsalva and the standing, there is a decreased preload, right? So there is a more LVOT obstruction and there is a increase in murmur intensity, right? So whenever you stand, the HOCM stands with you. You can remember this with the HOCM stands with you, right? So HOCM always stands with you and it always sits with you, right? So the squatting and hand grip associated with increased preload and which results into the lesser obstruction. Mitral regurgitation can be there due to systolic anterior motion of mitral valve closure, right? Double carotid pulsation could be there due to bifid atrial pulse, right? Then we can also get the signs of atrial fibrillation, pulmonary crepitation due to pulmonary congestion, and syncope could be there due to decreased cerebral perfusion, as we discussed earlier, right? So these are the signs that we can get. The important key signs that we must remember are spike and dome pulse, then double apical impulse, then S4, then harsh ejection systolic murmur, and the intensity of murmur that is increased in Valsalva or standing and decreased with squatting and hand grip. So this is all about the signs of HOCM. Moving ahead, now what is the investigations that we can do in HOCM? The first one is the ECG, which shows LVH, right? What are the ECG finding in left ventricular hypertrophy? We can get deep S1, right? We can get tall R wave in V5, V6. We can get S wave in first and AVL as well, right? So left ventricular hypertrophy we can diagnose in ECG. Then what about the echo? The left ventricular wall that is more than 15 mm usually associated with the HOCM, right? So the diagnostic criteria of HOCM is there is a hypertrophy or there is a muscle thickness that is more than 15 mm, right? Then we can also diagnose LVOT obstruction on Doppler waveform, and there is a dagger sign. So you will get an image in which there is a barcode image and it will shows this dip dagger like diagrams on Doppler waveform, and these are due to LVOT obstructions. Now let's move ahead with the treatment goals. The main focus for the treatment of HOCM should be there to improve diastolic filling so that there will be more distance between interventricular septums and left ventricular valve, right? So there is decreased LVOT, right? Relieve LVOT obstruction and prevent arrhythmias and reduce symptoms. So if we increase the diastolic filling, there will be eventually decrease in LVOT, right? And due to this decreased LVOT, there is less fibrosis formation and it can prevent arrhythmias as well. And this whole thing will reduce into the symptoms, right? So the first line drug for HOCM is a beta blocker. Now what is the mechanism behind this beta blocker use? So the drugs are metoprolol, propranolol, atenolol. How these drugs works in this HOCM is it will decrease heart rate, right? So due to decreased heart rate, there is an increased diastole, and this increased diastole will increase filling, that is diastolic filling. Also due to decreased heart rate, there will be decreased O2 demand, right? So the burden for contraction is also decreases. So this whole thing will increases the diastolic filling so that it will decrease LVOT and so as to prevent arrhythmias and the symptoms. In case of beta blocker cannot be used or it is contraindicated like few diseases like COPD, we start with the CCB channels, that is a calcium channel blockers. Drugs like verapamil, diltiazem are used if the beta blocker is contraindicated. What this drug does to the heart is it decreases the contraction. Due to this decreased contraction, there is a decreased demand, which also results into diastolic filling, increased diastolic filling, right? And so on, the process goes on. Like then there is also a third drug that we can use in HOCM, and it is a disopyramide. So it is a negative inotropic effect and it decreases left ventricular contraction and it decreases LVOT obstruction as well. The final treatment options for this HOCM is to put ICD, that is implantable cardioverter defibrillator, so as to prevent the life-threatening arrhythmias that occurs in HOCM, right? So what are the indications for this ICD implantation? The first and most important indication for this ICD is a previous cardiac arrest. So whenever there is a patient who is presenting to you with the HOCM history and there is a history of cardiac arrest, we must plan ICD in these patients, right? If the patient is having a sustained VT, then this sustained VT can be converted into the VF, which is a life-threatening and the cardiac arrest rhythm. So in this case as well, we have to put this patient on ICD. If there is a family history of sudden cardiac death, right? If the wall thickness is more than 30 mm, then surely this patient can be land up into cardiac arrest whenever it can. So better to start with the ICD implantation. Then if the patient is having unexplained syncope with the HOCM, that means there are few points when there is a decreased perfusion to cerebrum. So for this patient as well, we need to put ICD, and there is a abnormal halter. Like now there are few surgical measures that we can do in this HOCM as well, and it is a surgical septal myomectomy. So in this there is a dissection of septal hypertrophy, due to which we will decrease the hypertrophy. There is also alcohol septal ablation. In this case there is a controlled ischemia of hypertrophied muscle. What do we do in this procedure is we will inject small amount of alcohol and this will result into the ischemia, and this ischemia is very controlled way. So it is alcohol septal ablation, right? So this was all about the hypertrophic obstructive cardiomyopathy. Now the next concept is dilated cardiomyopathy. As you can understand with the name that there is a dilatation, right? The dilatation of ventricles that results into the dilated cardiomyopathy, right? So ventricular dilatation will be there with the systolic dysfunction, that is a reduced contractibility, right? The basic and the most important common cause about this DCMP is it is most of the time idiopathic and genetic cause. So it runs in the family and most of the time it is idiopathic. There are few infectious causes for this dilated cardiomyopathy, and the infectious causes like adenovirus, B19 and COVID as well. Also the Chagas disease, as we discussed earlier, the viral diseases and the Chagas disease that is associated with the dilated cardiomyopathy. The toxins also we have discussed, aldehyde in case of alcohol, cyclophosphamide like doxorubicin and daunorubicin that is usually associated with the dilated cardiomyopathy, like also the trastuzumab. Then heavy metals like cobalt, lead and hydrocarbons, right? Then the metabolic and endocrine causes. Now understand the thyroid disorders like hypo and hyper. These both conditions are associated with the dilated cardiomyopathy, right? So whenever there is a question, they will ask you definitely about the hypothyroidism, hyperthyroidism, pheochromocytoma and all of the above. So in the question they will definitely put this three options like hypothyroidism, hyperthyroidism and the chromocytoma, and all of the above, and the answer would be all of the above, right? The nutritional deficiencies like thiamine deficiency, that is the beriberi syndrome, and the selenium deficiency and carnitine deficiency. One thing to remember about this selenium deficiency is that it occurs at the sub-Himalayan area, right? And this disease is also known as a Kishan's disease. So there is a one-liner question about this, that they will just put the selenium deficiency is also known as which disease, right? So the Kishan disease is the answer. Now let's talk about the autoimmune disorders that is associated with this DCMP are sarcoidosis, hemochromatosis. Also there is a involvement of amyloidosis, which is a infiltrating disease. In this condition, mostly there is two types of cardiomyopathy we can get, like dilated and the restrictive. So in this case of autoimmune like sarcoidosis and hemochromatosis, we usually get dilated rather than restrictive. So the both concept, that both the element for dilated and restrictive will be there, but the more is for dilated one, right? Now let's talk about the pathophysiology of DCMP. Now the pathophysiology of HOCM and dilated cardiomyopathy is almost same, just the difference between the pre-existing conditions. Like here there are weak myocardium, and due to which there is a decreased contractibility of heart and incomplete emptying, right? So that's why the systolic function has been decreased. In the case of HOCM, there was a preserved function, but the structure was so hypertrophied, there was a decrease in preload and the outflow obstruction was there, right? So the basic mechanism differs, but the final outcomes is usually the same in both of the cases. Right? So there is a decreased cardiac output and the activation of sympathetic nervous system and RAS activation, right? Which results into vasoconstriction and fluid retention, as we discussed in the video for heart failure, right? So let's revise it again. Due to this systolic dysfunction, there is a decreased ejection fraction, right? And this decreased ejection fraction results in the decreased cardiac output. Now when this decreased cardiac output comes to the cerebral point of view, we get syncope due to decreased cerebral perfusion, right? Regarding the kidney, when there is a decreased perfusion due to decreased cardiac output, there will be RAS activation, and this will increase sodium retention and water retention, and this sodium and water retention will result in edema, pedal edema, right? Also due to the decreased cardiac output, there will be increased sympathetic activity. The sympathetic activities like vasoconstriction, increased heart rate, that is tachycardia. This will result into cold, clammy periphery. So these are the basic pathophysiologies and the cascade that we can get in a dilated cardiomyopathy. And this whole thing will turn up into the progressive heart failure, right? And one thing also to remember, the key point about myocardial remodeling and fibrosis. So basically this dilated cardiomyopathy results into the myocardial remodeling and fibrosis, and which result into progressive heart failure, and the complication that we can get are the pulmonary edema, functional MRTR, arrhythmia like AF, VT and VF. Though these arrhythmias are more common with HOCM, but still in DCMP also we can get this arrhythmias as well. Also there is existing of thromboembolism and sudden cardiac death, right? Key differences between the DCMP and HOCM is the basic pathology, right? There is a hypertrophy in HOCM and there is a dilatation in DCMP. The systolic dysfunction is present in both of them, and the clinical cascade, the basic pathophysiological clinical cascade is almost the same, which results into systolic and diastolic dysfunction, right? Now let's talk about the investigations. What are the ECG findings that we can encounter in DCMP? The first thing is LBB RBB. It is due to enlargement of cardiac muscles. Atrial fibrillation due to LA enlargement. Similarly, ventricular arrhythmias due to ventricular enlargement, and LVH pattern can be there in few cases. What about the echo findings? The hallmark feature for DCMP is dilated left ventricle or dilated ventricle, right? In addition to this dilated LV, there is a 4-chamber dilatation that is seen in advanced disease. Again, in echo, there is a reduced ejection fraction due to systolic dysfunction and the global hypokinesia due to diffuse poor myocardial contraction, right? So these are the investigation point of view. The treatment for DCMP and restrictive cardiomyopathy we will cover together, right? Moving forward with the restrictive cardiomyopathy. Now the name itself tells you that there is a restriction of dilatation, right? Dilatation of ventricles. So basically it is a diastolic dysfunction, right? There are majorly two causes for this restrictive cardiomyopathy. The first one is non-infiltrative causes and the second one is infiltrative causes. Non-infiltrative causes consisting of diabetes mellitus and the scleroderma, while the infiltrative causes is divided into two parts. The first one is intracellular, that is within the cell, and the intercellular, that is between the two cells, right? So intracellular infiltration, that is inside the myocardial cells, has majorly three diseases. The first one is hemochromatosis. Now, as we all know, hemochromatosis is the iron accumulation inside the cells, right? It leads to dilated cardiomyopathy more oftenly than the restrictive one, right? Next is a Fabry disease. In this condition, what we see is that there is a X-linked lysosomal disorder having a deficiency of alpha galactosidase. And this alpha galactosidase deficiency leads to deposition of glycosphingolipid, right? The accumulation of glycosphingolipid usually occurs at kidney, heart, CNS, and the skin. And in heart, it causes restrictive cardiomyopathy. About the Pompe's disease, it is a glycogen accumulation, right? In this case, there is a deposition of glycogen resulting from the deficiency of alpha glucosidase, right? And it is usually accumulate in heart and the muscles, right? This both Fabry's and Pompe's disease usually associated with restrictive cardiomyopathy and hypertrophic cardiomyopathy. So please take a note that hemochromatosis is mostly associated with dilated cardiomyopathy, while the Fabry and Pompe's disease is associated with restrictive cardiomyopathy and hypertrophic cardiomyopathy, right? Now let's talk about the intercellular infiltration. Now intercellular infiltration means there is a accumulation between the myocardial cells, right? The most common cause for restrictive cardiomyopathy is amyloidosis. It is the most common cause for restrictive cardiomyopathy. In this case, there is a amyloid deposition, right? Now amyloidosis is divided into primary, secondary, and the familial one. The important point to be noted here is the secondary amyloidosis is not associated with the accumulation in heart. So there is no restrictive cardiomyopathy that we get in secondary amyloidosis. The familiar version of amyloidosis associated with transthyretin related amyloidosis. It is very common previous year question in which they will ask you about transthyretin related amyloidosis, which is associated with familial amyloidosis, right? Another important cause related to intercellular infiltration, it is a Loeffler syndrome. What happens here is there is a chronic inflammation which leads to fibrosis leading to restrictive cardiomyopathy, right? Another one is tropical endomyocardial fibrosis. What we get in this condition is there is a eosinophilic infiltration which leads to restrictive cardiomyopathy, right? So these are the various causes of restrictive cardiomyopathy that we must understand. Now let's discuss pathophysiology of this restrictive cardiomyopathy. The pathophysiology starts with the myocardial infiltration or the fibrosis that we get in Loeffler syndrome or any type of condition that leads to endomyocardial thickening, right? What is the root cause for this cascade is it is a ventricles that become stiff and non-compliant What do you mean by non-compliant? There is a decrease in change in volume, right? So the myocardial compliance is decreased, which leads to impaired ventricular relaxation, which we call diastolic dysfunction, right? Since the ventricle is unable to get filled with the blood, we can say there is an increased ventricular filling pressure, right? Like end diastolic pressure. And this will produce more pressure towards the atria, and there will be biatrial enlargement. And due to this biatrial enlargement, we have a symptoms for right heart failure and the left heart failure as well. So if you talk about the right heart failure, we will get increased JVP, hepatomegaly, ascites, and peripheral edema. While in the other case of left ventricular failure, we have pulmonary edema, dyspnea, orthopnea, and PND. Right? The overall cascade will leads to decrease in stroke volume and cardiac output. And the final result what we get, it is congestive heart failure. And as discussed earlier, the symptoms for decreased cardiac output we will get as per the system involved, like CNS, like muscles, like myocardium, and the renal. Right? So this is all about the pathophysiology of restrictive cardiomyopathy. Now, what type of investigation that we will perform in case of restrictive cardiomyopathy? ECG will show low voltage complex. Echo will show you the normal size ventricle with the biatrial enlargement and diastolic dysfunction. What about the Doppler echo? There is a restrictive ventricular filling pattern, right? Since the ventricle are not familiar with the relaxation, there is a decreased filling. Cardiac MRI detects myocardial fibrosis or infiltration. So this is the gold standard investigation to diagnose restrictive cardiomyopathy associated with amyloidosis or any infiltrative cause. Right? For hemochromatosis, we have iron studies. For amyloidosis, we also have urine and serum electrophoresis. So these are the investigations that we can perform in restrictive cardiomyopathy. Now let's talk about the treatment option for restrictive cardiomyopathy and dilated cardiomyopathy. Now, if you think logically, what are the conditions that can occur from these two cardiomyopathies? We can think of this following changes like heart failure, MI, we can get arrhythmias and congestive heart failure. For the condition like heart failure per se, we have to treat with the 4 pillars like ARNI or AC inhibitors, ARB inhibitors, then beta blocker, then mineralocorticoid receptor antagonist, then SGLT2 inhibitors. For MI, we have to follow our STEMI protocols and NSTEMI protocols. For arrhythmia, we have to treat underlying arrhythmias as per the protocols of ACLS. So the main motto to understand and to treat the RCM and DCMP is to prevent the complications, right? The definitive treatment is for the transplantation, right? Cardiac transplant. So this was all about the cardiomyopathy. I hope you have understood very well. Thanks for watching. See you on the next video.